So I think we're live now. Hello everybody and welcome to this online discussion about the recently translated English language version of Professor Clas Rehnberg's Timbro report, The East German Phenomenon, the Development of Public Health and Healthcare Provision After the Fall of the Berlin Wall. My name is Richard Forsén and I'll be the moderator during this discussion. Joining us in discussing Professor Rehnberg's report here at the Timbro studios in Stockholm is Professor Clas Rehnberg himself, professor at the Department of Learning, Informatics, Management and Ethics at the Karolinska Institute in Stockholm. Välkommen.
Thanks.
Also joining us in discussing this report and its interesting subject area is Dr. Steffen Fleßa, head of the Department of Healthcare Management and vice principal at the University of Greifswald, who's joining us from Germany over Zoom. Herzlich willkommen, Professor Fleßa.
Thank you very much.
And before beginning this discussion and the introductions, I just want to make a quick note to our viewers on Zoom and on Facebook that you're very welcome to join us with your questions. There is a Q&A function on Zoom, if you're joining us on Zoom, and on the live video transmission on Facebook, there should also be the opportunity, the possibility to ask questions in your comments. And your comments will then be given by me to our discussants. So please join us. But firstly, a quick word about Timbro, our co-host of this discussion. Timbro is a free market think tank based in Stockholm. And it's at Timbro's fantastic studio that we're recording this discussion. So thank you very much for Timbro for this interesting opportunity to contribute with funding towards the English language translation of Dr. Rehnberg's report, which we are discussing here today. But now, some quick introduction remarks from my colleague at the Konrad-Adenauer-Stiftung in Germany, Frau Martina Kaiser. Frau Kaiser, bitte.
Thank you very much, Mr. Forsén, and good afternoon, everybody. And also from me, a warm welcome to this discussion. Before I start, I would like to thank Professor Rehnberg and Timbro for the good cooperation and for giving us today the opportunity to discuss the findings of the study. We very much appreciate the interest of our Swedish partners and colleagues in this topic. The present study provides not only a valuable contribution to the field of health sciences, but also helps us to get a clearer picture of where we stand with regard to public health and healthcare provision in East Germany 30 years after the German reunification. Finally, I also would like to thank my colleague from the KAS Nordic country project for having invited me and for giving me the opportunity to contribute to this discussion by giving some brief opening remarks. In my review, the report is perfectly timed in several respects. So on 3rd of October this year, we have celebrated 30 years of German unity. And for 30 years, Germany has been committed to leveling the economic performance and the social living conditions in the newly formed German states. Since then, extensive investments were made in order to compensate deficits in infrastructure and industrial development. In addition, substantive efforts were taken to even out standards of the welfare sector to those of West Germany. Among others, this applies to the healthcare provision and the pension system, as Professor Rehnberg's report points out. Despite remaining differences and challenges, the merging of Germany and the leveling of living conditions in East Germany have made major progresses. The present report underlines this with regard to the developments of public health and healthcare provision by referring to several important health indicators. The report is published in a never-known situation of public health emergency. For nearly 1 year now, the COVID-19 pandemic is keeping the world in suspense, and globally more than 1.2 million people died from the effects of the coronavirus. The number of confirmed infections has exceeded 48 million. In Germany and many other European countries, we experience a violent second wave of the pandemic. Today, the Robert Koch Institute reported more than 21,000 new infections in Germany, which is a new peak. Besides all other lessons learned or to be learned, the current situation shows how important strong and resilient healthcare systems are, not only for the management of public health crises, but also for their prevention. In addition, resilient healthcare systems are an essential precondition for economic and political stability and for sustainable socio-economic development. Living longer and in a healthier way, probably most of us wish to do so. Health is our most precious property, and at the same time, it's one of our fundamental human rights. Not only for this reason, providing strong and resilient health systems and equal access to healthcare provision without neglecting certain groups of the society should be at the heart of all states and governments. It is indeed one of the key elements of the 2030 Agenda for Sustainable Development, which had been adopted by the global community in 2015. Professor Rehnberg's report points out that by improving economic and social conditions in combination with advances in medical technology, considerable improvements to health and life expectancy are possible. I'm sure that the findings of the report will be very useful, not only for a better understanding of the differences of public health and healthcare provision between East and West Germany, but might also give indications for other regional contexts and future developments in the healthcare sector. Thank you very much.
Thank you, Frau Kaiser. Vielen Dank. Now, once again, reminding our viewers that you're welcome to join us and ask questions using the Q&A function on Zoom or by commenting directly on Facebook. Now we will listen to opening statements from our two discussants, beginning with Professor Rehnberg, please.
Thank you. As I've been working with health economics for many years, and my main research interest has been to look at how healthcare systems are financed and organized. And I've been very keen on doing comparative research to look at development over time, but also reforms. And in Europe, we have this division of healthcare systems between tax-based system and social health insurance system, where Sweden represents one, and or the former, and Germany, especially West Germany, has a long tradition of social health insurance system. And why did I write this report? Yes, I have come across a lot of research made in Germany about the function of the German healthcare system. But I also realized that there are several publications about the development of health status, and especially the improvement of average life expectancy in the former East Germany. And I found this developing both surprising, very positive, but I also realized that it has been given very little attention outside pure academic settings and the research literature. And then when we had this 30th anniversary of the reunification of the East and West Germany this year, I found it very interesting to try to write a popular scientific report about this. And because, as I said, that this is probably well known for many specialists and researchers, perhaps policymakers in Germany, but I think for many researchers also in Sweden, and even more policymakers and the general public don't know about this development. And I think it's of interest from different aspects. First, as I said, it's an impressive improvement. Usually it takes a long time to improve health status and to improve life expectancy. And now this has been done in the eastern part of Germany within 20 years, which is a very fast development in an international perspective. And I also think it's could give lessons about what are the reasons for this development. And as I point out here, and I rely on research that has been done in Germany, we see the importance of economic growth. There has been large investment, both from the government, but also some private investment here to improve the general infrastructure, but also large investment, as you mentioned, to raise the standard in healthcare. And we see that this has contributed to a remarkable rapid increase in life expectancy. I also think it could be seen as a natural experiment where we could try to identify what are the factors behind this rapid increase in life expectancy and in general welfare and health status. I don't think we have the final word said there, but I think it's important to point out that the factors are not only public health factors as behavior, prevention, but also the role of the healthcare sector itself. And this is the discussion that we have in public health. I mean, that we know that the health status in all countries is a function of several factors. It's not only the healthcare sector, there's also a lot of external factors here. And I think that this, by analyzing the development in Eastern Germany, comparing with the West, but also comparing with other countries, we might get knowledge about this. What I do in this report is that I give a little bit of a historical background here, because I think that Germany has been the standard for the social health insurance system, starting already with Bismarck, who started what is said to be the first universal healthcare system in the world. And it has then been extended from only covering employers to cover the entire population. And it's been a rather successful model for organizing healthcare, not only in Germany, but many other countries in Central Europe. And in Germany, it has been going on for many years. And the only two deviations we have is the Nazi period and the socialist period with the planned economy in the former DDR. And I could also see that when I summarized the development in Germany, that up until the late 1960s, the development of health status were rather similar in West and East Germany. And that was mainly an effect of reduced infant mortality, successful prevention and treatment of infectious diseases. But then from 1970 until the fall of the Berlin Wall, we can see a large difference to the disadvantage of the eastern part, which has to do with the problem with both external factors, with problem with economic growth, with the planned economy. We see less investment in the healthcare sector. The access to healthcare seems to be rather bad for especially the elder people. It's more the working population had better access than the elderly. And also the pension system, which affect the living standard, was at a much lower level in East than West, not only in absolute terms, but also in relative terms, comparing with the working population. And we could also see that the problem with the planned economy also led to a weak currency. There were difficulties to import innovative drugs and to make investment in new medical technologies. You could also see that there was a change in the provision side, that private practitioners were replaced by public institutions, and you have the same development in the hospital sector. And there are probably a lot of other factors here, as maybe also things that the exchange of research between East and West could explain some of this lack of access to modern technology. But then after reunification, we see all this large investment in infrastructure in general, but also the healthcare sector with the investment in the hospital sector, changes in outpatient care with transfer from public to private practitioners, and also the improvement of the pension system, which I think has been very important for improving the living standard for especially the elderly and the elderly poor. And we see this clear development of life expectancy. And also here, it's mainly the oldest part of the population who improve their life expectancy comparing with the situation in West. And it was probably those who suffered most from the situation in the former East Germany. We can also see that there are differences here that could help us to explain the development. That if we look at mortality rates, we see most improvement for cardiovascular diseases. And that might give some information about that. It's important that we have innovative drugs, can give the right treatment to elderly who get different kind of both acute and chronic diseases. We have the importance of new technology that we can see has we see a better access to that for the entire population. And we can see that this development is also unique in an international perspective. We could see that the eastern part of Germany now catch up with the western part. It's almost the same for some group. One example is only women who now have almost the same life expectancy in East and West. But you could also see that East Germany is doing better than most, I would say almost all former socialist countries east of the Iron Curtain. Even if they also do improvement, like in the Czech Republic, Poland, etc., they haven't got up to the level of former East Germany. Of course, I admit, and I didn't get into depth to a lot of other social problems and differences that exist between East and West. But I think it's important to keep in mind that when you compare former East Germany with the regions in West Germany, that you are then comparing with the most advanced regions in Europe and within the European Union. That the regions in Western Germany, that they have the best economic growth, the lowest unemployment, good health status, etc. So if you compare East Germany with other regions in Europe, you see that East Germany is at the same level as many regions in France, in England. There are actually some regions in northern part of Sweden who have the same development as East Germany. So I think that it's important to keep that in mind when you compare former East Germany with the regions in West Germany, that you are comparing with the regions that are achieving things like economic growth and employment at the best. So just to sum up here, I have pointed out that you can see how both the healthcare sector, but also public health, general health status is dependent on factors outside the healthcare sector, like economic growth, efficient institutions, the general standard of living, the pension system, etc. But it giving, for example, that we have this reduction in cardiovascular diseases, the mortality has gone down there, that investment in the healthcare sector, both when in terms of modern equipment, knowledge, skills, possibility to import innovative drugs are very important for the general health status and life expectancy. Thank you.
Thank you very much, Professor Rehnberg. And once again, remember to ask your questions on Zoom's Q&A function and on in the comment section on Facebook. Now, presenting our next discussant, Professor Flesser, joining us from Germany on Zoom. Bitte sehr, Herr Professor. Professor Fleßa, I think we can have you muted your microphone, maybe.
And I have to share again, I'm sorry.
Oh, it's all right.
Okay, it got mute. Can you see my screen now? Okay.
Yes.
Yeah, thank you very much for that opportunity. My name is Steffen Fleßa. I'm professor of healthcare management at the University of Greifswald. I was not born in Eastern Germany, but I have lived here for the last 16 years. And in particular, I worked, I did research on the healthcare system in Eastern Germany. And I would like to show where we are. We are here in Germany, and we are in the very northeast of Germany, in the state of Mecklenburg-Western Pomerania. And this is our university. I just mentioned that our university is the oldest Swedish university. We were founded during the Swedish time in our area. And when we had our 550 years anniversary, your queen, the Swedish queen, was actually our guest of honor. Yeah, what would I like to talk about? I would like to talk about the developments during GDR, and simply states that not everything was bad during GDR, in particular in healthcare. I also would like to talk about the developments since GDR, and not everything is good in this time. Then I would like to look at some explanations and also about the future. Well, what were the developments? Here, you already said rightly that there was a strong difference between before 1970 and after 1970. The story in the healthcare system of GDR before 1970 is a story of success. You had a very strong reduction of the number of healthcare facilities. I call this a success because we have really tried very hard in the West to reduce our number of hospitals, for example, and could not do it because of political reasons. This was no problem in GDR. We had very good vaccination rates, very good dental health, very good physical activity. In 1970, the average East German was much more slim than the West German, had better teeth, and really was in some aspects in a better condition than people on average in Western Germany. There's a strong increase in human workforce in healthcare. So the GDR really invested in that. And you had a very strong community care. On the right, you see a picture from Sister Agnes. Everybody in GDR knew Sister Agnes, a very famous movie star, traveling around on the countryside and doing community work there. And in particular, you had an increase in equity with fair access for the entire population to healthcare services. After 1971, these success stories could not be continued because of the poor economy and the very poor healthcare resources, and the infrastructure strongly deteriorated. I would like to show this with some examples from hospitals in GDR in 1989. The average age of building at that time was 62 years. The average age of psychiatric building was 81 years, and hospitals, 22% of the rooms had no proper heating, and there was extremely shortage of all modern equipment. And altogether, you can say that the general problem of the socialistic system in GDR were also seen in the healthcare system, like low inventiveness and little access to international standards of quality care, in particular of implants and of equipment. Well, what happened since GDR? Well, there were a number of social and psychological developments. First of all, we had extremely high unemployment rates, which we had never seen before and after that, since the Second World War. For many people, the end of GDR was a time of complete uncertainty and an unprecedented decline of the birth rate. What you can see here on the low right is the development of the birth rate. And you see that the birth rate in GDR in the 70s was much higher than in the Western German countries or states. And it was almost identical at reunification. And then it declined to about 0.8 So the gross birth rate of 0.8 is extremely low, and you can hardly find anything like that except in times of severe war. So it was really a time of so strong uncertainties that people did not even dare having children. The healthcare and healthcare developments which we have seen is, on one hand side, some aspects are poor, others are good. There's a strong deterioration of dental health, of physical activity. Body mass index has strongly gone up since then, and also the vaccination rates have partly, not everywhere, but partly gone down. What we also see is that the old GDR system of outpatient care, the polyclinic, was completely taken away, and only some so-called MVZ, medical centers, which were allowed to be developed since 2004. They mainly came up in Western Germany, but not in Eastern Germany. We have a few of them, but by far not so many. What we see on the other side are very strong investments, in particular into the hospital infrastructure. Since reunification, about 950 billion euro were transferred for social development from the west to the east, and a big part of them also in hospital infrastructure, so that sometimes the hospital infrastructure in the east is today even better than in the west. We have very little adjustment of hospital planning required. On the right, you see a map of Germany, and you see those areas in green where hospitals had to be closed in the last years. And you see, for example, in our state of Western Pomerania in the northeast, there is nothing which had to be closed. That is simply a result of very properly done hospital planning during GDR. We simply don't have these hundreds of small 50 or 60 or 70 bed hospitals which you still find in West German states. What we also have seen is a very strong privatization. We have today in Eastern Germany a higher rate of privatization of healthcare services than we have in the West. How can we explain this? Well, what we can see from all this is that health is not only a function of healthcare services. It is much more. It is a question of environment, of nutrition, of sanitation, of housing, of cohesion of the society, of freedom, and so on. And all this has an impact on the health situation in Eastern Germany. And of course, it is not only medicine, it's much more. It has also something to do with self-responsibility. I think if you are trained that you are the master of your life or the master of your health, then you have to take care of it, whether you're young or whether you're old. If you're trained that the government is master of your health and the government provides everything from the first day of your life to the last day, then this feeling of self-responsibility is not so strong anymore. That might be an explanation why people were very slim and had very good teeth in 1990, and today the situation is quite opposite between West and Eastern Germany. There might also be an explanation in materialism. Materialism is, of course, a very complex concept, but one aspect could be, if I cannot work, then I don't have a value, I'm worthless. In other words, if you are retired, then there is no reason really to live very long. So the silent death of the elderly, which we have experienced strongly during GDR time, might also be a consequence of materialism of that time. So what is the future? Well, the situation has completely changed. And if I look at my students, I can only say there is hardly any difference between a student from West Germany and Eastern Germany. Very often I can't notice it all. What we have today in the northeast of Germany, former GDR, is that we are really like an innovation laboratory where many innovations are developed, like, for example, here in the right upper picture, this telemedicine doctors, this is an innovation coming from here. The new generation, there might be some East-West divide, but in particular with the old generation, we see, for example, that former GDR has a lower rate of corona. We don't know exactly why, but it's a matter of fact. So what can we learn out of all of that? Well, first we have to say we must be fair and really make a proper analysis. And one statement is clearly not everything was bad in the healthcare system of GDR. It had advantages. What we can also learn from the GDR healthcare system was that not everything that was well intended was well done. It's not the same to think we want to do something good and then also come up with good results. We can definitely also learn for other healthcare systems that health is much more than healthcare. The healthcare system in GDR might be good or might have been good, but because of this general economic decline, it could not really keep pace with the international development. And what I would also like to stress is that it is a tremendous change which people have experienced, in which they had to accommodate fundamental changes. And we don't see that the people in Eastern Germany, with this really extremely high uncertainty, losing every ground which they had in 1990, still, we don't see any major epidemic of psychiatric cases or something like that. It's really amazing life's achievement of former GDR citizens that they could really stand with that. Well, with these few words, I would like to thank you very much, and I'm looking forward to your questions and discussions.
Thank you, Professor Flesser, for that very interesting presentation and summary of your own view of the subject area we are discussing. My first question is to Professor Rehnberg. Considering that your report focuses explicitly on developments in former Eastern Germany before and after the fall of the Berlin Wall, it's still hard to get away from that much of interest in the report is related to differences in the healthcare system of Sweden and Germany as it looks like today, and in the health insurance model. Could you mention that briefly with when you mentioned, for instance, the introduction of the Bismarck model, but could you summarize how the situation looks today for our viewers in Germany and Sweden and the differences between the overall system design of healthcare in Sweden and Germany?
Yeah, let me first say that you should really distinguish between a tax-based system like in the former GDR and the tax-based system we have in Sweden, the Nordic countries, the UK, etc. So in that respect, I think that, I mean, tax-based systems in well-developed countries have a good tax base. There are countries with good economic growth, so we could devote enough with resources into the healthcare sector, and we also have access to modern technology, innovative drugs. I don't think that it's so much to learn between former socialist countries and the tax-based healthcare systems in Sweden and other European countries. But I think the comparison between tax-based systems in, let's say, the Western world and the social health insurance system in the Western world, like in Germany, Netherlands, Switzerland, etc., gives some interesting differences here. There are also a lot of similarities, because I think that even if you call it a social health insurance system, it's a system which is financed by mainly public sources. The fees are mandatory. Premiums are not set according to risk. So in that respect, the financing side is very similar to a tax-based system. The difference is that you have a separation between the financing and the provision. And you have much more of private provision. You have probably more of competition, although you could see that there are reforms aiming at competition also in tax-based system here. By the way, one striking difference I see between, for example, Germany, Netherlands, and some other social health insurance countries and Sweden is the performance of elective treatment, where we have much longer waiting lists. And this is due to a lot of problem with lack of incentives, I think lack of competition, also minor freedom of choice for patient. I think that the tax-based system have something to learn from both Germany, but also other social health insurance system. Whereas, for example, when it comes to acute care, I mean, treatment, if you look at hospital mortality for stroke, acute myocardial infarction, etc., then you could see that there are almost no differences.
Professor Fleßa, you showed an interesting picture of Germany which illustrated the closure of hospitals and the quite stark difference between former Western Germany and former Eastern Germany, and speaking now about the differences in the design and the planning of hospitals. How come this difference is so stark?
Well, it has sometimes advantages to have a strong, strict, sometimes maybe even authoritarian government when it comes to closing down hospitals where everybody would agree that they are not needed anymore, but still for political reasons you can't close them down in a democracy. This happens or has happened for the last 30, 40 years in a lot of places in Western Germany, where I could give you examples of hospitals which have 50 beds and the next hospital is only 5 kilometers away. So everybody would say it does not really make sense. From a quality side, it's dangerous to provide hospitals which have such a low turnover. From a financial side, they are extremely expensive. Nobody wants to work there and so on. But still, if you belong, maybe if you are the district commissioner in this area, and you belong to the right party then, and you phone your colleagues in your state capital, then they will not close down this hospital. Even if nobody needs it and nobody wants it, they will subsidize it. This did not happen in GDR. In GDR, they were much more willing to close down small hospitals. Somehow in this area in Eastern Germany also didn't have such a high density of hospitals in 1945. But still, the decline of the number of hospitals and the increase of the number of beds per hospital was much higher in GDR than in Western Germany. And therefore, we can really say there it was an advantage to have a strict government rule. And today, if you want to close down a hospital, you will have a civil rights movement and you will have an uproar in the population and so on. And some parties, maybe some right-wing parties, will jump in that and try to get on this train and get with the people along. This is very difficult to close down hospitals today.
Professor Rehnberg, did you have a question?
Yes, I found this very interesting because in my report I could see that the change in the hospital sector in the eastern part now, you see much more of investment by private for-profit providers, and in western part you have still the tradition of a lot of private non-profit providers. Do you think this linked to what you just said here about closing down, restructuring the hospital sector? Does the government still have a possibility to manage these for-profit hospitals, or will the development in the eastern part be similar to what's been going on in the western part now with this change of ownership?
Well, the first thing what we have to say is that we had in 1945 also quite a big number of non-profit organizations in hospitals in Eastern Germany, in particular church-run hospitals. They were, with a few exceptions, strongly reduced. So until 1990, there were a few church-run hospitals left, but the majority, and there were no private hospitals left. The majority of hospitals were actually government hospitals. But after 1990, after reunification, the government realized that they could not run these hospitals. There were no non-profit organizations to take it over. So they gave it on the market, and the hospital chains, the commercial hospital chains, took over a lot of these hospitals. In Germany, we have what we call dual financing. That means a part of the hospital cost is financed by health insurances and a part is financed by the government, in particular investment costs. Building hospitals, equipping hospitals is financed by the government, irrespective whether these hospitals belong to an NGO or a for-profit organization or a government organization. They are all financed by the government, and the government makes a regional hospital plan. And once you are in this plan, then you will get government funds for equipment and for buildings. And therefore, the government has still some access also to private hospitals, to private for-profit hospitals, by saying, okay, but these services do not fit in this place because you are too small, you are too rural. The discussion becomes very fierce in the moment in the field of delivery services. We have some hospitals also in Eastern Germany which have maybe 200, 150 deliveries per year, which is by far not enough to recover the costs and also to keep up a high quality. But to close down a delivery ward is extremely difficult.
Yes, it's a big political issue in Sweden as well, especially in the northern parts of Sweden, regarding fusing specialized healthcare into very few nationally specialized treatment centers. So it's an interesting parallel between politics in two different countries. We have now started receiving some questions. One is from U1. Can you assess how much of improvement in health in former Eastern Germany then is due to changes in the healthcare system, and how much is due to changes in public health activities more broadly speaking? Professor Rehnberg, what would you say based on your report?
Yeah, that's a very classical question and discussion that I said that we could definitely not put the percentage of that, but I think that overall in history, external factor has been more important than the investment in the healthcare sector. But I think that development, not only this change that has taken place in Eastern Germany, but also overall, that I think that even if you can't set the percentage, I think the percentage for the contribution from the healthcare sector has increased. And especially when it comes to prevention and treatment of chronic diseases for the elderly, that innovative drugs, good elderly services are more and more important for public health. But still, there is the external factors and the things that we could influence by ourselves, our lifestyle, behavior, consumption, etc. And also things like the pension fund, the pension system. As I got impression when I read research from Germany that the elderly suffered quite a lot from a lack of pensions during the socialist period.
So wealth in a wider sense than just healthcare.
Yeah,
yes.
Correct.
Professor Flesser, you mentioned a difference in culture in your conclusion between being responsible for your health yourself, or the attitude that it's something that primarily the government is supposed to provide. Is this related to this question of what would your percentage be when it comes to what has caused the biggest contributor to health improvements in Eastern Germany?
Well, I don't think that we can assess this really in figures. Even if you had a very big model there, it would be very imprecise and most likely not significant, the differences. But generally, I would say it depends also what you define with health. Is it only life expectancy, or is it also quality of life? Because I think that quality of life really matters a lot. For most people, it's very important to have a good life while you are here. And therefore, I think we can do a lot there. And this feeling of I'm responsible for it, not only the government and not my employer, but I'm personally responsible. This really gives us not only that we invest more in prevention, but that we also have more the feeling of being able to have an impact on one's life. And I give you an example. In 1990, the East Germans had much better teeth than the West Germans. How did this come? Because in East Germany, every child that went to kindergarten, the first thing what they did is they took their toothbrush and started brushing their teeth. And in school, the same thing. And even in the work, every week, twice a week, they went out to do physical activity on their job. what happened in 1990? Well, some people decided that this is against liberty or freedom. So nobody could force the children to brush their teeth anymore. And it's also against liberty that you have to do physical activity. And suddenly, from one day to another, people stopped it. Or many at least stopped it, because they were not self-responsible for that, but it was somehow delegated to their employer or to the kindergarten or to the school or something like that. And I think it could have been accompanied by new investments into health promotion and health education, but this did not really come. The Western Germany, which was Germany's system, which was transferred to Eastern Germany concerning healthcare, was very much doctor-oriented. The Eastern Germany, this German system was more nurse-oriented, community worker-oriented, and doctors, of course, played a major role, but the community medicine nurse, for example, was already there and really worked. And then it was taken away. And only 20 years later, we had to reinvent it because we saw it couldn't work without it.
It's interesting. Did you have a question, Dr. Rehnberg?
Yeah, it's very interesting and I also realized that, as you said, all things were not bad. Some things were good, and you mentioned this preventive medicine, dental care, physical exercises, etc. But I still got the impression that this community medicine in former East Germany was very much focused on the young people, the human workforce. And do you agree that the elderly part of the population, they were giving lower priority and they suffered most from the lack of access? I mean, not only in terms of access to healthcare, but also low pensions, etc.
I would say that is definitely the case. One aspect is that in GDR, many people did not really fully retire when they got in the age of retirement, but somehow, at least when they were good, kept on working. I know from one bookkeeper who still was, when she was 80 years old, she still went for 2 days a week into her former office to support and to take care of very difficult things, because she liked it and they liked them and she really contributed. But once you were old and sick, you were somehow of no use anymore. On the other hand, you have to see that family bonds, because of the strict government, family bonds, at least it's my impression, were very strong in GDR. And the support of the families was very strong also for the elderly.
Interesting. This is now going on to another question we have received to Professor Flesser, first and foremost. Have you noticed any difference in terms of access to quality healthcare and healthcare equity and healthcare opportunity in rural areas after 1990 in East Germany, following this transition from to more private practices? Has it, for instance, become more difficult to recruit practitioners and specialists willing to work in areas with low population densities?
It's definitely a strong difference. We see this all over the world, that development usually means more concentration of services. The more sophisticated, for example, hospitals become, the more important is that you concentrate them, otherwise it's getting too expensive. But on the other hand, during GDR, the hospitals were really all around the area, and also there was a good public transport system organized. Today we have, for example, in our area, we have villages where there's only a public transport during school times. So Monday to Friday, when there are no school holidays. Otherwise, people have problems to get out of their villages and get to a doctor. So in some aspects, it was more accessible. The healthcare was more accessible during the time of GDR than it is today. And we are also suffering from a loss of population, in particular in rural areas. This is stronger than it is in other areas. All over the world, there's a move from rural area to urban areas. But in GDR, this was extremely high. In particular, after 1990, in the first 10 years, young women left the countryside and went in particular to Western Germany. which had a strong consequence on the fertility or on the gross birth rate, but it also had a strong consequence that the elderly were left alone. There was nobody who would take them by car to a doctor or so. And now we have a problem. There's no more post office, there's no more doctor, there's no more pastor, and now you still want to close down the small hospital in the next town. This is a real disaster for many people, at least psychologically. Maybe not in quality of care, but psychologically, the feeling of getting lost in rural areas. This is really an issue which we are fighting with.
This must also have interesting or very unfortunate political consequences, I'd imagine, in these communities in Eastern Germany as well, this feeling of being forgotten or the state, the social contract being hollowed out.
The right-wing parties in Germany are quite strong in these areas.
Professor Rehnberg, would you say that there are lessons that can be learned when it comes to this aspect of availability of healthcare in rural Sweden, considering the experiences in Eastern Germany?
I think we have the same problem here, and it's always a balance that how do you deal with the benefits of concentrating, because you know that concentration might lead to improvement in terms of quality here, and I think all systems have this problem here, and it's a very difficult balance here, and as I said, it's a kind of a psychological problem to get that a hospital or some kind of other kind of healthcare unit is closing down in a rural area. So yes, but on the other hand, people want to have the most up-to-date treatment with the best quality at the same time here. So it's a conflict, yes.
Moving on to a third question we received through Zoom. What is, in your view, Professor Fleßa, the biggest difference in healthcare in East and West Germany? Because I remember from Professor Rehnberg's report that there is still a difference in hospitalization tendencies in outpatient and inpatient care in former Western and Eastern Germany.
Yeah, I saw this, and I have to admit, I was a little bit surprised, I have to say, because this kind of social law is actually federal law. So in principle, people in West and Eastern Germany are entitled of the same healthcare services. There is no difference. And we have some problems with, for example, rural areas in the East to get sufficient number of doctors willing to settle down. But this is also in some area of Western Germany. So I would expect that the inequality is not so extremely bad concerning healthcare. There are other differences which we see. There are economic differences. Eastern Germany is still much poorer for income, but in particular also for wealth which you have. And this has, of course, an impact, for example, on life expectancy. A big part of the difference in life expectancy can be explained by your wealth and income. And as Eastern Germany is also much poorer still until today, it has an impact also on your life expectancy. But in principle, Germans are, wherever they live, entitled to the same catalog of services.
Professor Rehnberg, you had a question.
No, I don't know if it's fair to say, but sometimes I got the impression that public health systems are more hospital oriented. And I think that goes for the Swedish system as well. We have a very weak primary healthcare sector. And I think like West Germany has a long tradition of a very pluralistic outpatient care, good access, freedom of choice, a reimbursement system that encourage doctors to have a good access for both primary health care, but also other types of outpatient care. And I can also see that, like in Sweden, that investments to a large extent goes to the hospital sector, and we still are struggling with a weak primary healthcare sector.
Professor Flesser, would you say that this could be affected by maybe expectations among citizens being slightly different, even if it's 30 years after the reunification of Germany, that there is some kind of an expectation that you should receive in-hospital treatment when maybe that would traditionally not be as culturally ingrained among patients in Western Germany?
Well, of course, if you grow up in a certain culture and you have lived a big part of your life in this culture, this will be there for the rest of your life. It will always influence. But there might also be other reasons. We see that many people here in Eastern Germany, when they get sick, they have a tendency to go to the emergency department of the hospitals. Our emergency departments are overflowing. We have a similar tendency in the western parts of our country, but not so strong. Why could it be? It could also be because in many areas, the family structures have changed. Young people moved out. They went to Western Germany. They went to the big cities in order to get employment. And many older people are left alone. So at the end, their ability to go home and have somebody to take care of them might be different than in a traditional family in Western Germany. And this might also be a reason why people have a tendency to go earlier to the hospital and say, I would like to stay here for 2 nights or 3 nights. If ever possible, please admit me because I don't have anybody at home. Nobody can take care of me when I'm sick.
We are unfortunately running out of time, but some quick questions to both of you. Professor Fleßa, if you could steal one thing from Sweden's healthcare system, or what would that be?
I think the role which nurses play in Sweden. They are much better trained. They have for a long time had academic training, and they have a lot of rights which German nurses do not have. And I think we should also go more in the direction. It was already stronger during GDR time, and we are going in the direction to start academic training of non-medical professionals. And I think they will play a much greater role as community medicine nurses and as any kind of caregiver in future, highly professionalized, really well-trained people. And I think they are in Sweden far, far faster than we are.
Professor Rehnberg, if you got the opportunity to sneakily borrow something from Germany's healthcare system, what would that be?
Yeah, I think I already mentioned that I think you're doing a better job when it comes to elective treatment. You have a lower waiting list. And I think one reason for that we could learn from is to have a more flexible use of the human resources that you have invested in healthcare here. And I think that both the competition, sometimes also the reimbursement system, I think we could learn from. I mean, I know it's not perfect in Germany as well, but I think there are things that we can learn from there.
Wonderful. Thank you so much to Frau Kaiser, Professor Fleßa, Professor Rehnberg, and Emanuel, Anders, and Erik here at Timbro. It's been a lovely discussion. Unfortunately, we're out of time. I think we'll have to continue it in another occasion. Thank you very much, everybody.
Thank you very much.